Good day, everyone. Welcome to another episode of Ultrasound Podcast, where we bring together the best minds of ultrasound from across the globe. I am truly thrilled to introduce to you a very special guest today. He is none other than Professor Matthew Reid, all the way from Edinburgh, Scotland. Matthew is a dedicated emergency medicine consultant at the Edinburgh Royal Infirmary, Scotland. He is a phenomenal name in the field of medical research and point-of-care ultrasound. Matt is a professor of emergency medicine with the acute care group of the University of Edinburgh, immediate past professor at the Royal College of Emergency Medicine, and a consultant and NRS fellow at the Edinburgh Royal Infirmary. His passion for medical research has transformed patient care. His expertise in ultrasound is allowing for faster and more accurate diagnosis at the bedside. With his vast expertise and experience in emergency medicine and medical research, Matt is making a significant contribution to modern healthcare. Please join me in welcoming the extraordinary Professor Matthew Reid from Scotland. Thanks, Matt, for joining us in this podcast. It's a great privilege having you here today. Hi, Matt. Thanks for joining us. It's a great privilege having you here. Of course, we are in two different areas, and it's night in Melbourne, and I believe it's 10 o'clock in the morning in Edinburgh. Over the years, we are using ultrasound in the emergency department for the assessment of cardiac arrest patients, and we found from our personal experience, anecdotes, and a lot of research papers that ultrasound is affecting the patient assessment and management in cardiac arrest. Over the years, we noticed that the paramedics are also using ultrasound. And one of these important studies is this PUCA study, or the Paramedic Ultrasound in Cardiac Arrest, where you are the lead author and researcher. So, Matt, tell us a little bit more about this study. What has actually, what led to the inception of this particular study, Matt?
Sure. Thank you so much for having me on, Navajit. For giving me the opportunity to talk about the PUCA study. So this was a piece of work that we started on about 10 years ago now. In the UK, we were in the process of training our trainees in ultrasound. We'd established level 1 skills in emergency medicine, ultrasound, POCUS, and we put a lot of effort into training our trainees into learning a fairly basic echo and life support for in emergency department. So the start of this study was a paper we did looking at training all of our emergency department trainees and some of our consultants to provide basic echo and life support, which we termed ELS, in our emergency department. So we put a couple of days on, we trained them up to do it, and then we looked at whether we were improving the number of patients who got echo and how it affected the patient care. Now, around that time in Edinburgh, we were really lucky to have a really high trained group of paramedics who used to come in every fortnight into the emergency department to learn more skills. So there were about 10 or 15 of them, and they made up what was called the rapid response unit, and they provided advanced level skills mainly in cardiac arrest across Edinburgh. So if there was a cardiac arrest, the initially nearest paramedic team would attend, and then this team of highly trained paramedics would turn up a bit later on, due to obviously location, to where they're located at the time, to provide some advanced level skills, and also to provide some scene overview and managing the scene, decision making, and things like that. So they already had some advanced skills, and it seemed like a really good opportunity to be able to train them up in using ultrasounds in the pre-hospital arena, to look at a few questions. And the questions we wanted to look at were, first of all, can we train pre-hospital paramedics to be able to perform pre-hospital echo and life support. If we can train them to be able to perform it, obviously in a very difficult environment that's much harder to deliver practice compared to the emergency department resuscitation room, can they interpret their findings? Can they then retain these skills? So we have about 400 cardiac arrests a year in the Edinburgh region. And because this team going to a lot of these, they've got the opportunity to be able to keep the skills up. Otherwise, your normal paramedic may only see a cardiac arrest maybe once a year. So can they retain this performance and also the interpretation skills? We wanted to look at whether they were able to perform the ELS during the 10-second pulse check window. There was a lot at this time. The Resuscitation Council had just issued some guidelines which were very clear about the most important thing about managing cardiac arrest was reducing the hands off the chest time. And the last thing we wanted to do was introduce something that made that much worse and potentially was detrimental to the patient's care. And then finally, we wanted to look at were there any other unintended outcomes of introducing ultrasound pre-hospital to the delivery of cardiac arrest care. So that was the aims. That's why we wanted to go about doing this. And we were lucky enough to get a grant from the Resuscitation Council in the UK to be able to do this.
Yeah, excellent. I think this particular study has affected the way the paramedics assess the patients. Even in Australia, I know that some of the paramedics, they refer to this particular study. Thanks for introducing this new technique. And now with regards to the role of echocardiography in the pre-hospital settings, how do you find the paramedics dynamic of the patient management, especially in case of the time-critical emergency in a cardiac arrest? As you have mentioned, that every second is important, and the Resuscitation Council has got very strict guidelines that those 10-second window that should not be abused, that should be utilized very strictly. So how do you find the use of echocardiography by the paramedics change the dynamics of the patient management?
Sure. So I'll maybe touch on about why we thought this was important in the management of the patient. So as you said, there are guidelines on hands off the chest time, but in the UK, we also have the JR Calc guidelines, which is what this is the joint guidelines from the Royal Colleges about management of pre-hospital care by paramedics. And initially, certainly these guidelines suggest that paramedics can diagnose death, and if it's obvious, so there's things in the guidelines, obviously like severe trauma, where there's clearly things like massive injury, things where clearly the patient is dead on arrival. If they're not, then the paramedics can only call the end to resuscitation if they've been going on for 30 minutes and 20 minutes in asystole throughout that. And there are many patients that we were getting ad hoc calls from the crews in the hospital to say, this patient is end of life. They've had a cardiac arrest. We've been going for 30 minutes, but they're not in asystole, but we'd be keen not to transfer them because this patient clearly we feel is at the end of their life and that we want to cease resuscitation. And they were after something that might be able to help make that decision a bit easier. And also we know the other reason why it might be really important is we know that from previous studies that we do find things that might be able to change management within the pre-hospital setting. So, for example, we see sometimes a patient who has VF on ultrasound, which we haven't seen on the monitor, which we can shock. We might see someone with a massive right ventricle with a good history of PE, which we may be able to thrombolize because our paramedics carry thrombolytics. We may see someone with a massive pericardial tamponade or effusion, which may be the cause. And most commonly, we might see somebody who we think has got PEA, so no cardiac contractions. But when we put the probe on, we see that the patient has some degree of cardiac function. We know from things like the Paramedic study that's about 15% of patients who are thought to be in PE have some cardiac function. So that was where it sort of fitted into the management of the cardiac arrest at the scene, why we wanted to look at it. Do you want me to go on and talk a little bit about some of the findings we found at this stage?
Yeah, absolutely. Yeah, go for it. Thank you.
So first of all, we did a training situation, and we trained up all the paramedics, and we found that they could obtain xiphisternal views and parasternal views really well. And after the 1 day training, 88% of views, both for parasternal and subxiphoid, were of diagnostic quality. So within a day, we're able to train up paramedics to perform the scan. Their theoretical knowledge improved from a pre-test score of 54% after the day up to 89%. So clearly improving theoretical knowledge. And we also tested them all 10 weeks later, ensure that they retained the theory. So they got a score of 82% at 10 weeks, and they retained the practical. Mainly the subxiphoid view was much more easy to obtain if you weren't doing it all the time. The parasternal view dropped off a bit in the quality, but we were fairly happy that with regular training, they came to us every fortnight at this point to do a bit more training, that we could retain those skills. So 8 paramedics in the end passed the competency test and started practicing ELS in the pre-hospital arena. And they tended 45 patients throughout the study, where resuscitation was attempted and the echo and life support facilities were available. So we found that in 80% of these, they produced an adequate view, and in about 2/3 of these were classified as excellent views or good. And I should just say, actually, what we also had was all our paramedics had cameras on as well. So we were able to look at the effect on the resuscitation as well as looking at the images obtained. We found that just less than half of the views that were obtained were able to be obtained during the 10-second pulse check window. And through the cameras, we were able to see that the average time off the chest was 17 seconds, which is obviously more than the Resuscitation Council would like in order to be able to ensure that we maintain good coronary perfusion. We also looked around the scene at the time. So when we taught the paramedics how to do this, a lot of it was about the views, but a lot of it was about how to incorporate it into the resuscitation attempt. So we delegated responsibility for the pulse check to another paramedic, so that the one that was doing the scan didn't fixate on doing the scan and take much longer than was required to do it. But we still found that only about 2/3 of the time did the paramedic who was leading it defer that responsibility. Only about in 2/3 of the time did they actively count out. So the paramedic who the lead was deferred to actively counted out the 10-second pulse check window. And on some occasions, the manual pulse check wasn't performed because the echo obviously caused some distractions. So there was some issues around that. And again, the rhythm of the monitor as well was not as always checked as well as it could have been when the echo was being performed. We did have some decision changing scans, and that was around stopping. We didn't pick up any pathologies that would maybe change treatment of the patient. And because there is not enough evidence yet that having cardiac standstill on its own pre-hospital is enough to be able to know for certain that the patient won't make a recovery a complete recovery to hospital discharge. The fact that there was standstill on the monitor was also incorporated with the other clinical factors around stopping and a phone call to the hospital to ensure that the consultant in charge was happy that in this case it was satisfactory to stop. So all of the cases that a decision to stop came about through the use of ultrasound were checked with the hospital and the clinical scenario, and they were the main factors that we found where it changed practice. But I think the take homes were that we found that paramedics could easily perform ALS. They could integrate it into the cardiac arrest scenario. They were able to retain the knowledge that they'd learnt. They were able to obtain really good views in the pre-hospital environment, but that it did lead on some occasions to slightly longer hands off the chest time, slightly less pulse checking, and slightly less monitoring checking than was recommended.
Excellent. That was a very structured training program for the paramedics, and the good thing was that they could acquire the knowledge, retain the knowledge, and apply that knowledge for their decision making, which was fantastic. Now, my question to you, Matt, is this particular study was mentioning about ultrasound. Did you use only echocardiography, or did you use the other parameters of ultrasound, such as lung ultrasound or the fast scan? Because in the cardiac arrest, the reversible causes, the 4H and 4Ts, they include some conditions like hypovolemia, conditions like tension pneumothorax, or the pulmonary embolism. These are the conditions which can be identified by the extended use of ultrasound, not only echocardiography, looking at the heart only. For example, lung ultrasound, IVC, or the free fluid in the abdomen. Did you use that at all, or you focused only on echocardiography?
So yeah, I agree that shock scans that incorporate all those other types of ultrasounds absolutely have their place in the ED and possibly in the pre-hospital setting as well, in trained hands. But we were very much focused just on cardiac arrest. And I'm not sure of the benefit of doing shock type scans in cardiac arrest patients, because essentially we want to know what's the rhythm. Is there any obvious underlying pathology that is amenable to immediate treatment? And most of those other things that we might be able to pick up, we are hopefully treating as well. So, for example, if we are concerned that the patient, for example, things we can't normally pick up, such as maybe pneumothorax, we would hope that as part of our examination, we would listen to both sides of the chest. If there was any suggestion of trauma or tension, we would treat that without needing ultrasound. So we very much focused on cardiac arrest itself. And we kept it as simple as possible, just because we were aware how difficult for anyone in the pre-hospital environment it is to perform ultrasound at a very skilled level when you're not doing it every day. So I know in Australia, you've got the Coach Red protocol for ELS. We used a slightly different one. We used the MF-RFC. So all we were looking for was motion. We were looking at function. R was for rhythm. Was there VF that we weren't expecting? F was for fluid. Could we see any fluid around the heart? And finally, C was for chambers. So is there any obvious right heart dilatation, bearing in mind that may be normal in cardiac arrest? So gross right heart dilatation. So really basic ELS.
Yeah, I thank you for clarifying that. Now, obviously, you mentioned about the very structured training of the paramedics, and there are quite a few studies. One of the studies that you have mentioned in your paper was the paper from Susan Price and the colleagues. They use this one-day didactic training, theoretical training, and hands-on training, and they found that even the novice with very limited knowledge and expertise can learn the basic echocardiography in life support, or ELS, knowledge and skills. And also, I think there is one of your paper where you have mentioned the similar thing, that one-day training in the emergency department has significantly increased the use of echo in life support, and also it helped or improved the decision-making process. In these studies, or from your experience, do you feel that this one-day training is good enough, or like advanced life support in the UK, they need to do it again every 4 years? Do you have anything like that in case of the echo in life support at all?
So when we set this up, the paramedics were complete novices, had never used ultrasound, had never seen an ultrasound machine, whereas some of our ED trainees and consultants were a bit more familiar with ultrasound. I'd say this was at a time when ultrasound was really in a boom for training in the UK. So a lot of people had started doing level 1 courses. I think that this is something that you need to be regularly doing. I think you probably need to be doing a scan a week at the very minimum to be staying competent. And we commonly find that if people have had a period when they've not been scanning, simple things like where does the probe go, which the orientation of the probe, what my settings I'm using, which chamber is which on the heart, are easily forgotten unless you're doing it very regularly. So with our paramedics, we had them back every couple of weeks for a whole lot of training, but we also added a little bit every so often of ELS practice. And our trainees, and our consultants in the ED, we try to encourage its use in all cardiac arrests.
Thank you, Matt, for the explanation. Now, with regards to the impact of the patient outcome, from your experience or from this study, what do you find? What is the implication of the use of echocardiography by the paramedics in the pre-hospital setting on the patient outcome, especially in terms of the survival rates and the decision-making in the pre-hospital environment?
Yeah, absolutely. So I touched a little bit on this. I think we weren't surprised to find that the main area that pre-hospital ultrasound impacted was to help the decision of futility, to aid that decision about transportation or not. So I think ourselves in the hospital, when we got the call, along with the paramedics, felt they were more comfortable making a decision in someone who they were probably planning on stopping resuscitation anyway, that they could see a heart that wasn't moving at all, that they'd already covered all reversible causes and had no reversible causes at the point when they were considering stopping anyway, that it provided that extra reassurance that there was really nothing more that they could do. This patient had a dead heart. So I think we always thought that was where it was, the utility was being the greatest. We didn't look at outcomes in our patients. We didn't find any positive findings. And I know studies such as Reason have shown that there are patients who, if we see cardiac activity on the ultrasound in PEA, have a slightly better survival to hospital discharge. I think it was about 4%. Of those who had any activity on ultrasound in PA had a survival to hospital discharge compared to those that had no activity. And I think those patients in the pre-hospital scene much earlier on obviously have a much better chance if you see some cardiac activity in PA compared to by the time the patient comes to the hospital. The Reason study also showed that there are a small number that got thrombolytics and a small number that got pericarditis, but we didn't see any of that, although we only had sort of 45 odd patients. I'm not sure that there is enough evidence yet, or there's any evidence that using ELS pre-hospital improves outcomes. I think there are patients who, the odd patient here and there, that may benefit from finding something such as a pericardial tamponade or a effusion or a massive right ventricle. But it's very difficult to tease apart those patients from those that we were maybe suspecting this in already, and we're thinking about possibly this is a PE, and the ultrasound findings are confirmatory. And I think that's similar to our practice within the ED, that lots of the time you expect to see the findings that you find. But there will be occasions when you put the probe on a patient who's unwell and you see a big pericardial effusion, and that's the cause of their breathlessness and you hadn't thought of it. So I think it's going to be very difficult as part of a trial or study to show benefit, because there is benefit, but it will be in a small number of patients.
Yeah, I completely agree with that. Thank you for that. Now, what about the paramedics' perspective? How do they take this new responsibility of the use of echocardiography in these cardiac arrest scenarios? And what type of feedback did they provide regarding the effectiveness and feasibility of this new technique?
So yes, so our paramedics are in Edinburgh all extremely enthusiastic, really keen to learn new skills, and really embraced the PUCA study and learning ultrasound. The study ran for 2 years. At the end of the study, it was possible to carry on. We'd got the infrastructure in terms of the 3RU team. We also had the ultrasound paid for through the grant to be able to use pre-hospital. But so a few things transpired all at once, really, to mean that we ended up stopping the program. And that was, firstly, that one of the benefits to the paramedics that they suddenly had lots more skills is that they became able to apply for lots of more advanced role jobs, and some of them moved to the EMRS, which is our helicopter emergency medicine retrieval team, where they became critical care paramedics. So we lost a few to that. The scheme itself then became one that, rather than just being in Edinburgh, was adopted by the Scottish Ambulance Service on a nationwide basis. So the highly trained paramedics just within Edinburgh were, rather than us training them locally, became trained on a more national level. And also, as part of that, because of this slightly longer hands off the chest time, it was decided that we wouldn't incorporate ultrasound into a new proposed algorithm to use across the whole of Scotland. So it wasn't something we could do just in Edinburgh. It had to be incorporated into a Scottish-wide programme, and it was felt that the evidence for improved outcomes, when you weigh that with the level of training, level of expertise required, the level of keeping up skills that was required, that at this point in time, there probably wasn't that evidence there to go ahead to train everyone up in Scotland who is attending cardiac arrests in ELS.
Right. First of all, the paramedics took it positively, which is great, but I'm sorry to know that it did not go any further. What is the future plan? Do you have any plan to reintroduce it, or modify it in any other way, or improve or change the training program?
So since the study, Scotland now has 4 trauma centres, and we have 3 now EMS helicopter retrieval services that cover the west of Scotland and north of Scotland. We had a land-based vehicle in the southeast, which there's possibility at some point in the future may become a helicopter retrieval service. So they still that includes a physician and a critical care paramedic, and they all use ultrasound pre-hospital. They use it on cardiac arrests. They use it in trauma patients. So it's embedded within those services. But we're no longer using it in the field in Edinburgh. We did have a physician response vehicle in Edinburgh, which also had ultrasound capabilities. At the moment, that's not running because we are possibly moving to a helicopter EMS service. But that's the reason why it's not been used within Edinburgh, but is still incorporated as part of the helicopter EMS team. And I think that's means that the critical care paramedics and the physicians are using it very regularly. They're going to lots of cases, and they're becoming very skilled in it. And they can then add on all those other skills you've talked about before: lung, shock, fast scanning, vascular access, pneumothorax, and things like that. So you can increase the scope of the ultrasound to increase the benefit of it, because I'm not sure ELS alone has enough impact on resuscitation to justify the training requirements for it.
Do you feel that this particular study, PUCA study, has actually influenced in the acquisition of the retrieval services to use the ultrasound? Do they have any impact at all?
I think within the retrieval services, they are looking at many more indications for ultrasound. So it's not just about assessing the evidence in cardiac arrest, it's also looking at where it can help in other things as well. And I think the evidence is clearly there that in trauma and shocked patients, people who are acutely breathless, peri-arrest, the ultrasound is absolutely vital to be able to rule in and rule out certain diagnoses. So I'm not sure whether our study has any impact on whether these teams are using echo in life support, but I think the fact that they will have their teams that are much more have much more time for training, they're doing more cases, they're seeing more of the advanced cases. It means that kind of technology can be embedded. I have seen quite a lot recently over the last couple of years looking of studies and reviews looking at echo in life support. And I think from what I'm reading, the general summary does seem to be that, for example, the ERC, European Resuscitation Council, and the American Heart Association have both discouraged the use of echo for prognostication based on the evidence. ACEP, I think, have recommended it to help distinguish between asystole PEA and pseudo PEA. But I think we're still not quite clear yet of the role that ELS can play pre-hospital in cardiac arrest. Certainly, I know it in the last resuscitation guidelines, it has been incorporated in hospital for, if available, it should be used. But clearly, the in-hospital environment is very different to the pre-hospital environment.
Yeah, there is a lot of scope of further studies, and a lot of works needs to be done before we actually incorporate this. I think that is the bottom line from my experience and from what I read. Now, with regards to the comparative analysis between the traditional methods in the good old days when we use the pulse check for 10 seconds, and now we can use the echocardiography. From your experience or from this particular study, what do you find? What is the comparison between the use of the echocardiography or ultrasound and the traditional methods?
Sure, yeah. So with the cameras, we did look at the resuscitation that was performed using the echo, and I did say obviously that there was a increase in the hands off the chest time, reduced pulse checking, reduced monitor checking. But what I have to add is that we didn't look at what the standard is. So it may be that in a difficult pre-hospital environment with difficult patients, environments, areas where you're trying to manage resuscitation, that we're not achieving a 10-second hand off the chest all the time, and we're not achieving 100% pulse check, and we're not achieving 100% rhythm check. So we didn't look at what the standard was. So it might be a bit harsh to say that it's slightly increased time off the chest. We do just have assumed that without the use of echo that we were meeting the resuscitation guidelines. Although I should say that there was a lot of audit that went on around this time of hands off the chest time generally, and within our setting it was very good.
Excellent, thank you. And what about this ethical consideration, Matt? These paramedics were using this ultrasound. Obviously, they have trained in the emergency department, as you have just mentioned, in a very structured way. But enabling the paramedics to make this critical decision on the basis of echocardiography or incorporating in their decision-making process, what is your take on it? What is the ethical consideration?
Yeah, sure. So obviously this was forefront in our mind in designing the study. And we were very clear that the ultrasound wasn't going to be the sole determinant of patient management. So no decisions were made purely on the findings. They were incorporated into the general clinical picture, and a consultant was available within the hospital to phone for any patient where the paramedic felt they wanted to stop resuscitation and felt it was appropriate to stop resuscitation. So we were using it as an adjunct to standard care. We weren't using it as a replacement for standard care.
Thank you. So Matt, in the emergency department, you have seen lots of patients with cardiac arrest who had been brought in by the paramedics from the community. From your experience or during this study, did you find any case study, or do you like to share with us any of those cases where the echocardiography was used in the pre-hospital setting, or was there anything that you find interesting?
Sure. So within our 45 patients, we didn't find any cases where a patient had a finding on echo apart from standstill or function. Obviously, we didn't find any pathology, but obviously with many years of practice within the emergency department, I've found there are many patients who we have found findings in the peri-arrest or cardiac arrest scenario that have changed our management. A patient comes to mind a few months ago who came in peri-arrest, breathless, who on performing a very basic ELS as part of their workup, their ABCD approach, I was able to see a large thrombus in the right atrium, clearly diagnostic for pulmonary embolism, which obviously clinched the diagnosis. It meant we were able to stabilize them, confirm diagnosis with this patient once we stabilized them on CT and thrombolize. We managed to keep the patient stable enough to be able to confirm that. But if they had deteriorated further prior to CT, we would have been more than happy, clearly, to thrombolize them on the basis of the echo findings. Mm-hmm. So that was certainly one that I remember. And there have been a few patients as well over the last year or so who I have seen within the emergency department, not within our resuscitation area, who've come in mainly with breathlessness. And one occasion I've found a very large pericardial effusion that I wasn't expecting to see. And I remember another patient, fairly young patient, who had a very dilated baggy cardiomyopathy, which again was a finding that we weren't expecting to see, and had come in with a week or two's history of breathlessness. And had clearly had a cardiomyopathy developing over the previous few months, which I don't think I would have picked up without the use of ultrasound.
Yeah, thanks for sharing those excellent cases. It's really interesting to see how the echocardiography or ultrasound can give us some sudden shock that, oh, we are not expecting, but it is there. It's amazing. Now,
sure, I get our trainees and our consultants, once they've learnt echo, to scan every patient that they see who's got breathlessness, just to keep the skills up. And also, as I say, on occasions, you do find things that you just weren't expecting.
Exactly. Yeah, from my experience, I have got a similar type of experience that chest pain, shortness of breath, you do the ultrasound or echo and you find some really big pericardial effusion, maybe a pneumothorax, free fluid in the abdomen. There's so many times this has happened. It's amazing.
Yeah, absolutely. And just the recently there's been the fundus study looking at echo in aortic dissection, adding into a workup protocol of aortic dissection as a rule in. And there's a very nice now algorithm for scanning patients who you think have got chest pain or who you think might have aortic dissection, to rule it in, looking at some direct and some indirect findings, which requires that slightly higher level of cardiac ultrasound. But again, I think if incorporated really well into a really nice algorithm, is something that's probably very achievable by most physicians who do ultrasound.
I agree. So, Matt, what are the implications you feel of this particular study, the PUCA study, to emergency medicine? Because those patients are ending up most of the time to the emergency department. How do you find it has actually affected the assessment and management of the patients in the emergency department?
So I think from an emergency department perspective, it's vital we use these tools, ELS and other ultrasound scanning, on patients who have undifferentiated shock or cardiac arrest. I think it's within our armory. It's something that clearly changes management and is a window on the heart to underlying pathology. So I think it's absolutely important that we do that. And I think now all of our trainees and anyone coming through in the UK is trained up on doing echo and life support. So it's a generic skill that everyone has. And we're finding that people now want to go on and learn more cardiac skills because they realize the benefit of it. In the pre-hospital setting, I think ultrasound has its place, as we've said, in a well-developed system that's entirely delivering just a pre-hospital service and not one that's led out of the emergency department, because that means that you're seeing specialized patients. You've got time for training, time for audit and education. You've got time to practice and simulate, and a lot of sick patients to be able to keep skills up in this regard. So I think it certainly has its place there as well. I think I would like to see I think this study is really important in the fact that it's very easy just to say, we've got this tool, let's just use it. It's got to be beneficial. We must use this. Let's train everyone up to do ultrasound pre-hospital in cardiac arrest because it must be beneficial. And I think this is important because this study really shows the implications of introducing that. It shows the training requirements, the effort that's required to train people up to do it. And it shows also what findings we may see and how that might affect outcome. And I think we really need to be showing that if we're going to introduce an intervention like this, it clearly has an important benefit to patients. And that might not just be benefit in terms of survival. That might be us not over-resuscitating patients, bringing patients to hospital when they're at the end of their life. So the benefits are not only in terms of survival, But I think we need to clearly show those before we start introducing these technologies into the pre-hospital setting or into any setting.
Agree. Thank you very much for sharing that. Now, Matt, you have been using echo in the emergency department for many, many years. And from this particular study, you have got that expertise in dealing with the paramedics as well. Now, what will be your advice to the clinicians, the paramedics, the medical students, or the young doctors who are willing to learn ultrasound and use the ultrasound in their day-to-day life or day-to-day activities, especially in the time-critical, life-threatening emergencies like a cardiac arrest or a peri-arrest scenario? So what will be your advice? What will be the take-home message?
I think we've already got a head start with ultrasound because it's quite cool. It's quite fun to learn. It's quite fun to do. So it's not something that we need to persuade our trainees, medical students, too hard to get involved with. When we run ultrasound courses, we always get medical students along as models and to practice ultrasound as well, so they can get some exposure to it, to get some of the learning. So I think that's an easy win. And I think they start to see the benefits themselves when they start scanning. I think it's really important to make sure that they keep their skills up, to regularly scan, to not overextend themselves with their skills. So when you get very enthusiastic about ultrasound, it's very easy to say, oh, I want to do some DVT work, I want to do some kidneys, ultrasound of gallbladders, musculoskeletal work. It's very easy to take on a huge amount of indications, but it's very important that you keep your skills up doing these things. So make sure that what you do, you do it well.
Excellent. Thank you very much for sharing that. There are quite a few references that we have mentioned. These are for our viewers who are interested to know more about this study and the relevant or related studies. Once again, thank you, Matt, for sharing your wealth of knowledge on this topic. And we learned a lot of interesting stuff. And I hope that our viewers can use this knowledge and expertise for their clinical practice as well. All right. Thank you very much for taking your time. And I hope that we'll see you soon.
Thank you ever so much for having me on. It's been an absolute pleasure.